Hello everyone. Today we'll discuss about meconium aspiration syndrome. So starting with the incidence of this meconium aspiration syndrome, nearly 10 to 15% of the deliveries account for meconium stained liquor. Okay. Among this, 3 to 12% of the neonates born through this meconium stained liquor or meconium stained amniotic fluid develop meconium aspiration syndrome. Of neonates, born through meconium stained amniotic fluid develop meconium aspiration syndrome. Okay, these are highest in the post-term infants. This is about the incidence of meconium aspiration syndrome and meconium stained liquor. So what is a meconium? What does it contain? So meconium is a sterile, thick, black-green, odorless component. So what is a meconium? It is a sterile, thick, black-green, odorless substance. What are its components? Meconium and its components. So it is made up of 72 to 80% of water. It contains desquamated cells from intestine and skin. It contains desquamated cells from intestine and skin. It also contains gastrointestinal mucin. Fourth, it contains vernix gaseosa. It contains langohair. It contains the glycoprotein from the blood group. From the blood group, it contains specifically its glycoprotein. Bile, enzymes such as phospholipase A2 and amniotic fluid. So these are the components of meconium. That is, it is made up of 72 to 80% of water with desquamated cells from intestine and skin, gastrointestinal mucin, vernix gaseosa, langohair. From blood group, it contains specifically its glycoprotein, bile, enzymes such as phospholipase A2 and amniotic fluid. So what is the pathophysiology behind the meconium aspiration syndrome? We'll see that. We'll see the pathophysiology. So, in the meconium stained amniotic fluid in the postterm fetus, it is due to the motilin level, increase in the motilin level and normal GI function. So, meconium stained amniotic fluid. What is it due to in postterm infants? In postterm fetus, it is due to increase in motilin level with normal GI function. Third, it is because of vagal stimulation due to the cord or its head compression. it can also be due to the in utero fetus stress. Okay, so the meconium stained amniotic fluid in postterm fetus is due to increase in motilin level with vagal stimulation due to its cord or the head compression. Here, this meconium stained amniotic fluid, it can be of three types. That is, it can be thinly stained or moderately stained or thickly stained. So a thinly stained is watery. Moderately stained, it will have opacity, that is, it will be opaque but no particles. Thickly stained, it will be like a pea soup. Okay. Next. So the fetus with the meconium stained amniotic fluid, the aspiration can occur. The aspiration of this meconium stained amniotic fluid can occur during in utero or during the labor or just after the labor. So why it occurs in utero? How it occurs in utero? What is the cause? It occurs in utero due to fetal stress such as chronic hypoxia, infection. The aspiration occurs in utero due to chronic hypoxia or infection. Okay. So due to the chronic hypoxia or the infection, there will be gasping of the fetus. This leads to aspiration of meconium. Okay. So severe MAS is caused by the in utero process only. So after this aspiration of the meconium into the fetus, what all it affects? So effects of meconium aspiration. First, it can cause peripheral airway obstruction. This peripheral airway obstruction, it can be either complete obstruction or a partial obstruction. In complete obstruction, this peripheral obstruction is mostly the smaller airways. So when it is completely obstructed, it leads to atelectasis. This in turn leads to ventilation perfusion mismatch. Okay. This ventilation perfusion mismatch in turn can lead to acidosis, hypoxemia and hypercapnia. Okay. If it is a partial airway obstruction, there will be a ball valve effect which leads to air trapping, in turn leads to air leaks. Okay, this air leaks will also cause these major things, that is hypoxemia, hypercapnia and acidosis. So when it is this occurs when there is a peripheral airway obstruction. When there is a proximal airway obstruction, it leads to air trapping which in turn leads to air leaks and acidosis, hypoxemia and hypercapnia, or directly it leads to this hypoxemia, hypercapnia and acidosis. This meconium can also cause release of cytokines and vasoactive substances. These cytokines and vasoactive substances, these cause an inflammatory process. This in turn leads to chemical pneumonitis, which again leads to hypoxemia, hypercapnia and acidosis. Okay. Meconium can also disrupt the surfactant function. So this can also disrupt the surfactant function, which limits, so therefore it limits the ability of the surfactant to lower the surface tension, thereby leading to respiratory distress syndrome. So it limits its ability to lower surface tension, okay, thereby leading to respiratory distress syndrome. This continued compromise due to meconium aspiration syndrome, so when there is a continued compromise due to meconium aspiration syndrome, it can also cause vasospasm and remodeling of pulmonary arterial muscular. It can cause vasospasm and remodeling of pulmonary arterial musculature. Thereby it causes PPHN, that is persistent pulmonary hypertension. This persistent pulmonary hypertension causes right to left shunting, that is extrapulmonary right to left shunting, which in turn can lead to this acidosis, hypoxemia and hypercapnia. Okay, so these are the effects of the meconium aspiration syndrome. So what are its severity? So how is the severity being classified? So severity is being classified as mild, moderate and severe. In mild, the child requires a less than 40% of oxygen less than 48 hours. Moderate is, it requires more than 40% of oxygen for more than 48 hours without air leak. In severe case, the child will require a mechanical ventilation for more than 48 hours. This can be associated with persistent pulmonary hypertension. Okay. So what are the management of meconium aspiration syndrome? So in delivery room, I'll write the management here. Delivery room, you should check whether the child is vigorous or non-vigorous. In vigorous child, the child will be breathing well and the tone will be good. In non-vigorous child, there will be a feeble breathing with low tone. So vigorous child only needs observation. In non-vigorous child, you should do the resuscitation according to the NRP guidelines. Okay. So in observation, you should check for, you can take a chest x-ray for the child. What does the chest x-ray will reveal in a meconium aspiration syndrome? In chest x-ray, the findings will be, there will be a coarse nodulation, that is diffuse opacity will be present. There can be asymmetric patchy infiltrates. There can be consolidation. This consolidation can be more on the right. Plus there can be hyperinflation. Okay. Next you have to monitor for baby's SpO2. Okay, this is the in a vigorous child you have to do these measures. Plus you should also look for the normal care of a neonate. How will you see in the NICU? That is, you should maintain the child in a thermoneutral environment. Second, you should monitor its blood glucose. Calcium should be, serum calcium should be maintained to the normal level. If suppose there is any metabolic acidosis, it should be corrected. You should give the circulatory support. You should maintain HB at 15 gram per deciliter. That is, PCV should be maintained between 45 to 55%. Renal function test should be monitored. Chest physiotherapy should be avoided because it can lead to potential adverse effect of exacerbating PPH. So you should avoid chest physiotherapy. So how will you give? This is the normal monitoring or care of a neonate with the meconium aspiration syndrome. Next is the oxygen therapy. In oxygen therapy, you should manage the hypoxemia by increasing its FiO2 by monitoring its ABG. So you have to manage hypoxemia by increasing its FiO2 by monitoring its ABG. Okay. Next is assisted ventilation. You can use CPAP in this child, in this infants, if FiO2 requirement is more than 40%. So if FiO2 requirement is more than 40%, you can give a trial CPAP, but you should be careful in giving CPAP because it can lead to, it can also cause adverse effect of air leak. Then mechanical ventilation is used in the baby with a severe meconium aspiration syndrome with gas exchange abnormalities. That is, when the child has PaCO2 of more than 60% and the PaO2 of less than 50, or the pH is less than 7.2, with FiO2 of more than 40% or more than 60%, then you use a mechanical ventilation for this child. So ventilatory support acute is in a SAMV mode. So you do in a mechanical ventilation, you give it SAMV mode. You should maintain PEP of around 14 to 18 centimeter of water with that is a high inspiratory pressure. With tidal volume of around 5 to 6 ml per kg, with PEEP of around 4 to 6 centimeter of water and inspiratory time it's maintained around 0.35 to 0.5 second. Okay. There should be an adequate expiratory time to prevent the air trapping also, and you maintain the rate at 30 to 40 beats per minute. Okay. Supposing if in this condition, if it is not improving, if the child is not improving, or when you find an air leak syndrome, it's an indication you have to change it to HFOV, or you can give ECMO therapy if there is respiratory failure. Okay. This is about the ventilatory management or ventilatory setting in a child with meconium aspiration syndrome. What are the medications you can give in this child? Medications you can give, a broad spectrum antibiotic can be given. Surfactant replacement can be done. Sometimes it can improve this oxygenation and reduces the need for ECMO therapy, this surfactant replacement. You should sedate the child if the child is in a ventilator. Okay. Next we'll see the complications. So complications of meconium aspiration syndromes are, first is air leak syndrome, third, they can develop persistent pulmonary hypertension. Third, they can have pulmonary sequelae with the abnormal pulmonary function. They can require supplementary oxygen even for 1 month. There can be pulmonary sequelae. Because 5% can require supplementary oxygen for 1 month also. These children can also go for neurodevelopmental delay. Okay, this pulmonary sequelae, in this the child will have can develop hyperreactive airway disease, or the child can develop recurrent pneumonia. Okay, this is about meconium aspiration syndrome. Its incidence, its meconium contents, its pathophysiology, its management, and these complications. Okay, thank you. Next topic I will cover the GINA guidelines part 2, that is in children less than 5 years of age. Okay, thank you. Have a nice day.